I'm Dr. Allan Perel, and this is Conversations in Medicine. I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. Today's program is about pain. Pain is ubiquitous. Everyone has pain at some time of their life. There's so much so that pain has now become a medical subspecialty, where there's actually a training session for people to become pain management specialists. Pain can be in any part of the body. There are different types of pain, definitions of pain. My wonderful guest, my friend here today, is Dr. Ken Chapman, who is a pain management specialist. And Dr. Chapman is an assistant clinical professor at NYU Langone and director of the pain management team at Staten Island University Hospital. Welcome, Ken.
Thank you for having me.
We're going to talk about pain. And if I ask everybody what pain is, most people will have different definitions. Some of it is ouch, some of it is burning, some of it is tingling, some of it is just discomfort. As a pain management specialist, what does pain mean to you?
Well, along those lines that you said, there's different types of pain. And so there's pain that can come from structures in our body, such as our bones, our nerves, our muscles. And then there's neuropathic pain, which is pain from irritation of nerves, which should be tingling and burning and some of those other things you said.
So there's a lot of different kinds of pain.
Yeah.
So in your specialty of pain management, how do you assess someone who comes in? If I had severe pain and I went to my primary care physician and they said they're really not sure what the cause of it is, and they've done a large workup, is that where you come in, or do you come in only after someone has a clearly diagnosed cause?
Well, typically patients will present to us with pain of a longer duration or pain that is more severe of a shorter duration. So there are times where they come in and we need to get more tests, but many times they've had a complete workup and they've done all the conservative measures.
So different kinds of pains, and I'll mention some just to sort of get us started. Things like cancer pain. I mean, I know there's some wonderful cancer centers out here in Manhattan, and I know you also work in Manhattan. Tell me about how you treat someone with cancer pain different than someone with, say, with back pain.
Well, you know, when you're dealing with a patient with cancer pain, sometimes it's a little more complex. We really need to work closely together with their oncologists and have an idea of what's going on, what type of cancer it is, what's our life expectancy, and our goal there is really patient comfort and quality of life issues. So sometimes we have less things to worry about with those patients, because really our main goal is, you know, making them comfortable and quality of life.
Tell me about joint pain. I mean, orthopedic pain is one of the most common causes. I see your finger is a little bit messed up.
Yeah.
You were playing basketball, I think you told me, and
Yeah.
I'm sure it hurt. And so tell me about orthopedic pain, whether it's hip pain, knee pain. What kind of things could a pain management specialist help compared to the orthopedist, or how they add to that?
Sometimes, well, we see a lot of patients with joint pain. It goes hand in hand with aging and back pain. So we see, you know, a ton of patients with arthritis of the hip, arthritis of the knees, shoulders. You know, essentially, what we can offer for these patients are precise injections. So, say an injection into your hip joint, into your knee joint, and have it be done in a way where we can actually know for sure that it's where it needs to be.
How do you know that?
We would look. It's performed under a fluoroscope, which is essentially a lifetime X-ray machine, and we use a little bit of dye or contrast, and you see it spread around in the appropriate structure, and it'll let us know that it's exactly where we want it to be. There's also, you know, there are some newer procedures where we can actually use a needle and burn some of the nerves to the joints. We do that in the spine already with a lot of success, but with there's new technology that allows us to do that for knee pain, for example, as well as for hip pain.
A lot of times when I was in medical school in residency, a lot of us would give just a small shot of cortisone in certain muscles and feel that it was helping. And there is some benefit to that. It sounds like you've gone a step beyond that with pain management in order to localize where you're putting the medicine with steroid, which are an anti-inflammatory medicine, or a lidocaine derivative. Lidocaine, as we all know, when we go to the dentist, to help numb the area. So tell me a little bit about how that step is really more specific in helping patients in a little different manner.
Well, with any steroid-based injection, you know, it's about the accuracy of where you're placing it, and using the technology we have available today with the equipment we have, we can place very small doses of medication right where it needs to be, rather than flooding your body with, say, a steroid and having a couple of molecules get to the spot we want it.
And why would we be concerned? What side effects would you have with
Well,
that?
you know, steroids, we know that over the long haul, they can cause bone demineralization, fluid retention, your skin to get thin, your veins to get weak. It can lead to adrenal failure. There's a lot of issues with.
So we don't want people on steroids for high doses for a long time,
Absolutely
obviously.
not.
Okay. So tell me about back pain. Back pain is one of the big pains that we have in common. As a neurologist, I see a lot of people with back pain, pinched nerves, herniated discs, whatever, different words that we use. And sometimes people get confused because a herniated disc is actually a part of the disc, which is the gelatinous material between the bones, and I know we have the model here, that actually pushes on a nerve, causing a pinched nerve. So they're not different diagnosis, they're actually really the same. It's really the cause of it. So maybe just for a minute or two, show us what we have with the spine, and we'll talk about a little bit how we could help people with chronic intractable pain.
So our role as a pain management specialist, we're part of a team of people that takes care of these patients. Very often when it comes to chronic pain, there's no magic bullet that's going to just make everything go away. And it's adjusting the pain, helping the patient's quality of life, having them involved with therapy or different medications to help with the pain. So with injections for the spine, there's as you just talked about the discs, those are right between the bones here, and the nerves come down from these are just the big nerves. There's tons of other nerves that can be pinched from that herniated disc. And we try to place a small amount of medication where the problem is and help the person get over the issue.
So what's that called? I mean, people talk about cortisone shots, epidural nerve blocks. Maybe give us some words, because in case someone goes to their doctor and they recommend some type of procedure, they'll know exactly what you're saying.
Sure. I mean, there's quite a few of them. The one that most people have heard of is an epidural steroid injection. That's the placement of a small amount of steroid right where the nerve is being pressed on. There's also, on the back of the spine, we have joints, and this goes for the cervical or lumbar, where we can place a numbing medicine and a steroid. There's, one of our better procedures we can give patients longer-term relief for a chronic condition is going in and burning the tiny little nerve branches that innervate these joints. Those are some of our more common ones. There's the sacroiliac joint, which is down here in the buttock. This forms your pelvis here. You can have arthritis or pain coming from that joint. And we see a lot of patients that have had surgery already and have persistent pain. And there's a couple other treatment modalities that we can offer those patients as well.
While we have the model out, we talked about cancer before and osteoporosis, thinning of the bone. You've given lectures, and I've been involved with you with a number of our cases in common of people who have what's called a compression fracture. And sometimes that's a very scary word. When I tell a patient they've had a compression fracture, they're concerned that their bone is broken, which almost by definition it is, because we're using the word fracture. And you have some very interesting procedures, pain management specialty has very interesting procedures for it. So maybe tell me what a compression fracture is, and really define what we call it, acute versus chronic, and how would you decide to treat it?
So if a patient comes in and either they have been diagnosed with a compression fracture, or they just have back pain, the first thing we're going to do is look for an X-ray. And what you'd see in that is these, the vertebral bodies here in the front of the spine, these are sort of the bricks of the spine that hold us upright. As we age, there's a couple common causes. The most common is osteoporosis, but trauma is another cause. Things like cancer and hemangiomas can lead to compression fractures. And what happens is this vertebral body here, because of osteoporosis, which is a weakening of the bone, through trying to lift something or trying to do simple things like lift a hamper or open a window, this weakened bone can collapse on itself, and that's called a vertebral compression fracture. So many times these things can get better on their own, but not all the time, or the pain can be too severe. And if the pain, and these patients typically are elderly in age, and if the pain is too severe and a patient can't get out of bed, can't take care of themselves, has to go to the hospitals, in the hospital, which has its own set of issues, there are risks to all of those things. So if the patient isn't getting better with time, then there's a procedure where we can actually put a trocar, a little needle, through with a patient essentially awake for it, through the bone into the fracture, and put something called methyl methacrylate, which is a sort of bone cement, which stabilizes the fracture and hopefully helps elevate the end plate of the compressed fracture.
It's almost like a balloon blowing it up a little bit? Or?
Well, one of them is a kyphoplasty, and that involves a balloon where the hope is that we can elevate the vertebral body a little bit. And another one, we use sort of just a cannula and put the cement in there. It's called a vertebroplasty. And you mentioned cancer before. There's a new procedure which is useful for patients with cancer within a vertebral body. So certain cancers tend to spread to vertebral bodies, and we can actually use this, access that vertebral body, and with a special device, we can actually burn some of that nerve, burn some of that cancer, because what happens is that cancer grows in there and it starts pushing on everything and can cause pain. So it's a newer procedure which is good for patients that have metastases to the bone.
And that happens not uncommonly, sad to say, in
Yeah.
people with metastatic breast cancer or prostate cancer.
Absolutely, and it's one of the hardest. With just medicine alone, it's very hard to treat. And even with radiation therapy, which is the mainstay treatment now, it takes the time to get pain relief is a little bit longer. And this is something that can be used with radiation therapy for better outcomes.
And what I've seen with pain management over my number of years in practice is really how much more specialized you become. Where if someone's got a problem with their hip, we inject a hip or we try to give treatment to that area. If someone has a problem with the spine, even compression fractures where people in the past really weren't treating them. Now we're much more aggressive because we're able to get to that spot using smaller catheters, smaller needles, without doing open major procedures. Tell me a little bit, we're going to talk about some medicines now. And as a pain management specialist, as you know, opioids, there are pros and cons. I mean, we see so many tragedies of young people overusing them.
Absolutely.
We see a lot of people dependent on them. But clearly there's a purpose for them, and in your specialty and my specialty, we use them. And you have to use them because people have pain. And we've spoken before about the pendulum shifting back and forth. Tell us about how you use opioids, how you decide if someone should be on a narcotic or opioids, and how do you monitor them?
Yeah, so that's the opioid subject is a very broad subject to go over. There's quite a bit of questioning there. I think to begin with, we want to try things to limit people from taking opioids, or try to avoid them from heading down that path. And that's through some of the modalities that we've spoken about before: the therapy, the chiropractic, perhaps injections. And we want to keep patients on lower doses for shorter periods of time if possible. You mentioned the pendulum. Previously, over the last 15 years, say, the use of opioids has just skyrocketed. And that was for a lot of reasons. for the drug companies marketing, the patients wanting it, the doctors saying okay to it, and we've realized that pain is something that we have to deal with, at least to some degree now, and patients understand that as well. And so we, as pain specialists, one of the hardest things is talking to a patient and spending the time to say, hey, we're not going to use opioids here. You need to deal with this a little bit, or we're not going to go up on medicine. That's one of probably the harder parts of the job. And then another hard part is monitoring patients on these medications, because we have to make sure they're taking them in the right way.
So tell me, how do you monitor? And you use opioids.
Yes.
And all pain management, but vast majority, I'll say, never say all, but use opioids to some degree. So if someone comes in, these are patients who are the most intractable. My treatments usually don't work, whether it's physical therapy, we talked about different rehabilitative therapies and treatments that hasn't worked. And you decide somewhere along the way that opioids need to be given in order to work, function, do whatever. Mm-hmm. How do you decide not just which opioid, but how to monitor someone that they're not taking too much, that it's not affecting their lives in different ways?
They came out with essentially the state mandated that there are certain things that needed to be done in order to help physicians have a guideline as far as how they should be treated. One is that every patient that comes in, we need to check it, and they created a database because it didn't exist before, but you can see where every patient fills this prescription of opioids and who wrote that prescription. So if a patient comes in, we just look online and we can see what they've had, who wrote it, when, how much. So that's the first step, that every single time a patient comes in, that's checked to make sure they didn't go to someone else, or they didn't, for whatever reason, they didn't have anything that they didn't tell us about. Then another thing is we do something called random drug testing, which is through collecting urine and running that for metabolites of different drugs, illicit drugs, or other narcotics, to make sure they're not taking drugs from other people. That's done on a random basis in conjunction with risk factors and the amount of medication a patient is taking.
So there's a lot of different things that you do. And of course, we all try not to have people on those medicines. We try to use other kinds of medications like Tylenol, Motrin, muscle relaxants in order to reduce the need for the opioids. But again, we all have patients who do need some. And in that case, we just want to use the smallest doses, as you said, in order to get the benefit. Tell me, what do you think about family help with regard to chronic pain? You said before about people having to live with some expectation that there might be some pain. I mean, being pain-free is difficult. Going to that 100% is always hard for all of us. Now, with regard to the family and caregivers, care partners, what's your impression of them in the pain management field?
Well, having support is always important. So, obviously it depends on the patient, but we could talk in general terms. An elderly patient, which is someone that we see, every other patient's probably above 65. Having the support and help of family is very important for a lot of reasons. One is just to help get everything that we say, and someone else to hear what's going on, because that patient may not be able to relay this information to a family member. They may not remember everything. There's some things that patients may not be able to do on themselves. If it's simple things like get rid of rugs, have a grab bar in the bathroom, store the medication away so they know how to take the medication. Family members are very important to be able to assist people with this.
Tell me about functionality. I know we have our friends in the physical therapy field, physiatry, who do a lot, even in my field of neurology, where we really look at functionality, how they're able to do their activities of daily living. I know, interestingly enough, different places in the world have different aspects. I know you practice also in Manhattan, so there's a different need, cars, not driving, the kneeling buses they have. Tell me a little bit about what you think of how do you assess and how do you try to get people as functional as you can?
Well, that's a good point you bring up, because as we said earlier, we can't necessarily get rid of all people's pain. markers of success to me is an improvement in your functionality. Are you doing things that you couldn't do before? Are you able to enjoy things that you weren't able to enjoy when this pain started? And really it's just speaking to the patient, understanding what their limitations are, understanding what they want to do, and if it's realistic for them to be able to do that.
Interesting. So let's talk about some cutting edge issues. I have a cutting edge pain management specialist here, and people throw out terms to me and things that I say, wow, that's interesting. You talked about nerve blocks and rhizotomies. Tell me about stimulators, implantable devices, things like that that are more long-term vagal nerve stimulators, so all kinds of different things that I hear about. And maybe tell our audience who's always interested in new things, what's going on, especially since many of us, have gone through many of the routine things. And I think what's so interesting is that people maybe 5, 10 years ago went to a pain management specialist, and at the end they said, this is about where you're going to be. There's really nothing more we could do. What kind of new things, what new things are available that maybe someone who 5 years ago wouldn't have benefited going back to a pain management specialist might be able to get some benefit with?
Well, you talked about this nerve stimulation or spinal cord stimulation. There's new technology. Essentially, they've been able to build and grow, and we're able to really help people a lot better than we were in the past with the older technology. And we have essentially new places to put these devices, which it's all done. You can have these performed with you yourself being awake. It's low risk. It doesn't hurt much, and you're able to see if it helps you before you get it. So there's just an incredible amount of advancement with spinal cord stimulation, and people that we weren't able to help 5 years ago, many of them were able to help now.
But let me go over a little bit more. People talk about the pumps of medications, even opioids that are used. Are we still doing that now?
So intrathecal pumps, they're called. It's essentially a device which administers a very, very small amount of an opioid into the spinal canal. And they are used still. I would say that they're used more for patients with cancer pain that are on very high doses of opioids, but they're still also used for patients with benign pain or non-cancer pain that are on high level of opioids, are not able to get the pain relief that we want without side effects.
Tell me a little about nerve pain. I mean, I'm a neurologist. We take care of patients with peripheral neuropathy or burning pain. I watch television. I like watching television, not only our show. And I see commercials for all kinds of pain syndromes. Patients with diabetes have, we call it neuropathic pain. And this is where we overlap. Where I have patients who have something called complex regional pain syndrome, as you know, used to be called reflex sympathetic dystrophy, very large words, for irritated nerves that cause burning and pain. And we have a lot of people in common, even people who've had post-shingles pain, they call it post-herpetic neuralgia, where you sort of say to yourself, I have certain choices in medicines, and we've worked together trying to get these people to be comfortable, and hopefully the process gets better or we go to the underlying disorder. So tell me a little bit with nerve pain. And as I said, we've had very good success using some of the medicines that you hear on television, and drugs like Lyrica or Neurontin, gabapentin. What's your approach to people with nerve pain, especially when I send them over to you and we've already gone over a lot of different things?
Well, it depends. If they've already tried it and been through a couple of the nerve pain medications, we were talking about spinal cord stimulus. The new technology is very specific to where we can place this device essentially on one nerve alone. And so we can shut off the pain transmission from just the nerve that goes to your foot, for example, by placing a very, very tiny wire on this nerve right here, the L5 and the S1, and essentially turn off the transmission of this nerve pain from really any part of the body. It could be used in shingles, it could be used in RSD or CRPS, as well as in diabetic neuropathy or any neuropathy essentially.
So we talk, and that's marvelous, because I have to say that people in my practice and throughout the country who've had pain that has been really intractable and the medicines haven't worked, or no matter what efforts we have, the idea that there's more and better and different things that are out there is really giving them a lot of hope and help functionality tremendously. So thank you, and that's something that's so important. So let's talk a little bit about your team. You know, I know that you're not by yourself in some little room doing everything yourself. First of all, tell me about the relationship between the pain management people and surgery. Funny thing, my mom just had her 2 knees replaced a few years ago, and she did well, thank goodness. And she had this pump put in, and she had no pain for the first day. And I know pain management is heavily involved with a lot of the surgical procedures. So tell me about the relationship with surgery, and then we'll talk a little bit about the team of people that work with you.
Sure. So, I mean, there's different aspects. There's an acute pain team which takes care of patients right after surgery, and we do things like epidural catheters, where it'll put numbing medicine on the nerves, or nerve blocks post-surgery, or pre-surgery for post-operative pain. That's part of what pain management specialists do. We cover patients that are in the hospital that they might need help with medications or for procedures on. And then we are on the outside as well, taking care of patients that many of them are either preoperative or postoperative for one type of surgery or another. Our main goal is to hopefully try to help you avoid getting surgery. But that being said, unfortunately, you know, surgery is still necessary in a fair amount of the cases. And, you know, we work very closely with surgeons, and, you know, we will try things. Either the surgeon will say, hey, could you try this nerve block at this level? Or we'll discuss with the surgeon, we've done this, and this so far. You know, what do you think from a surgical aspect? So it's important to have a very good dialogue. Or as patients we shared, where we said, listen, Dr. Perel, we've done these couple things. What do you think is going on here? Because we don't know from our aspect.
Tell me who your team is. Who do you work with? When you go into a pain management specialist office, who is the team of healthcare professionals that really are together? And what are their roles?
Within our office,
yeah.
We have, within our practice, we have six pain physicians that will do procedures, see patients, see the people in the hospital. We have another 5 or 6 mid-level practitioners, which are physician's assistants or nurse practitioners. And their role is to also help see the patients. They don't necessarily do the procedures, but they will watch the patients, help them with their medications, and do some of the work that it's hard for us to do for every single patient. And then we have an anesthesiologist. For some of the injections or procedures you can have anesthesia with. But there's a large group of people that
And I know you have wonderful nurses, you have wonderful people. And again, I'm talking about it in a whole, not just specific to your practice, but just in pain management as a whole. There's a whole team. It's not just the person giving the injection, it's the person watching them before, watching them after.
Absolutely. And
it's really important to have these done in proper settings, whether it's in a hospital setting, whether it's an outpatient setting. Our time's up. I want to say thank you, Ken. It's a pleasure to see you. You know, we always see each other, and you do such a wonderful job with our patients, and I want to say thank you. And I hope our audience has learned a lot about pain management. And I want to thank our wonderful producer and director, David Marcos, for all his help he's had through the season.